I'm going to go ahead and get started because we do have a packed agenda today. Um, Good morning, everyone, and thank you for joining. If I could ask you in the chat line and the chat box to uh, just sign in with your name and your organization so we can um, keep that information. We are recording this and we will put it up on the AHI website in a day or so. We usually have it up there as well. We'll share the slides. This morning's slides are minimal, but obviously we'll share them anyway. And if there is any additional information that people want, don't hesitate to ask. As you can see, we do have a packed agenda this morning. I'm going to start off with just a few updates with PCMH, but we have Ann Morgan from the North Country Healthy Heart Network talking about the chronic disease self-management. Katie Cook's got some great information about telehealth and updates on that. Megan Murphy's going to give us the view of what's going on with the COVID vaccine. And then, of course, Brenda will round us out with our quality metrics and start talking about some of the electronic clinical quality metrics. Just as reminders, every month we'll just have a one slide or so about PCMH and any of the criteria that people are working on. Please, by all means, if you have questions or if you have topics you want to discuss about PCMH, make sure you send me a little email and let me know, and we can spend some time looking at particulars. It is 2021, so it starts the new round for recognition. At this point in time, we have no information that says there'll be any extensions. So your submission will be due 1 month prior to your original anniversary date. So you kind of have to make sure you know what your anniversary date is. Obviously, it is noted in QPAS as well. If you have multiple anniversary dates because you have multiple sites and submitted different ones at different times, you can always submit to the earliest anniversary date for all of them, but you must submit to those organizations by the anniversary date, or actually the month before. A reminder as well, for 2021, you should be reviewing version 6 of the criteria and the 2021 annual reporting standards and guidelines, and those can all be found as well. They're already populated in QPAS, but you can also find the information on NCQA. If you need any of that information, don't hesitate to reach out to me. The other call out I wanted to remind people is that when you're submitting evidence, you have to submit evidence within the past 12 months, but it has to be information after your last submission. So if you submitted on 11/30/2020, where many of us did, the information that you might have to submit if you're due in April has to be between December 1st and the April timeframe. You can't go back further than that November date. And then as well, another gentle reminder, just making sure you're following the rules for site-specific versus shared. We had some confusion about that as we were submitting here in November. The latest tracker grid, and I apologize, I thought it went out earlier and people started emailing me saying, you know, where's the latest and greatest? So that was my bad. It is now been distributed, and I'm gonna work with our internal people, Philton, to see if we can't get that put up on our website page so you could just go and grab it if you, you know, you're working on it or whatever, you misplaced it. Lord knows I do that plenty of times. Any questions or comments or anything about people's submissions that they wanted to share? Okay. Next up, we do have Ann Morgan from the North Country Healthy Heart, and I'm going to pull up her slides.
Good morning.
Good morning, Ann.
So yeah, Luann, thank you for pulling up the slides. These are just a few quick slides to give folks a little bit of, actually I tucked the background in the back at the end of the presentation because I see that time is short. But just quickly, the North Country Chronic Disease Prevention Coalition is actually a program of the North Country Healthy Heart Network. We are located in Saranac Lake and currently have a grant that covers, a Rural Health Network grant that covers Clinton, Franklin, and Essex County. You know, the Heart Network has been around since 2000. It was established by a collaborative of healthcare providers and community agencies to really be a neutral organization that could bring diverse partners together to prevent chronic disease. So our mission is to design, develop, and help implement strategies to decrease the incidence of cardiac disease, stroke, and related illnesses in Northern New York. And our role is really to help our partners build capacity for implementation of chronic disease prevention programs and activities. As I mentioned, we do have a rural health network, and that's really the focus of this presentation today. I want to share with everyone some exciting work that we're doing and an even more exciting opportunity that we have to expand and grow that to cover the ACO's entire region. So the North Country Chronic Disease Prevention Coalition is really focused right now on increasing regional capacity to deliver evidence-based support programs. And we're specifically focused on 3 programs: chronic disease chronic disease self-management program, the diabetes self-management program as administered through SMRC, and the National Diabetes Prevention Program. The reason that we're focused on diabetes, Luann, if you want to just go to the next slide quickly, is that just based on the the data that we've collected through the HCSCNE diabetes registry, we do have access through Power BI to aggregate data. You can see that in the North Country counties, we have very high rates of patient population with diabetes. And even more alarming, if you go to the next slide, Luann, is that we have a large proportion of those individuals who have diabetes that's with an A1C at or greater 9, which is out of control. And I don't really have a national benchmark to compare that to. I would be interested, I don't know, maybe Ruth Ann, I see you're on the call. You might have some national benchmark data to look at to see how we compare, but rates at this level seem quite alarming. So Luann, to the next slide, what the Rural Health Network has been doing is, again, really focusing on building that capacity. So with partners in Clinton, Franklin, and Essex County, and I should say the support of a technical assistance partner in St. Lawrence County, we've been able to get 21 program leaders trained and now having the capacity to serve a minimum of 126 program participants in 2021. And that equals about 0.5% of the pre-diabetic and diabetic patient population in these 3 counties. And our 3-year objective is to get to, having capacity to serve at least 2% of the patient population with these programs. So next slide. So that work that we've been engaged with has been supported, like I said, through a Rural Health Network grant. As many of you may know, I know some of you know directly that our Rural Health Network grants have been cut pretty significantly. So we've been looking for other ways to supplement that funding stream to allow us to continue our work. And there is a very exciting new opportunity that's available through the Administration for Community Living. And the funding that's available would actually allow us not only to continue growing the work that we've been doing in Clinton, Franklin, and Essex County, but to expand that to reach the entire ACO region. And so this is a very quick introduction. I would love to talk with any of you or all of you, offline about what we're doing. But we do have a specific ask right now, which is, we're looking for letters of support from primary care practices, as well as other community partners. And the primary care practice role in the model that the coalition has been developing is really critical, where we're really looking to partner with primary care to drive referrals to these programs. So using the tools available through HCSNE, or possibly you have other internal tools that allow you to increase identification of individuals that could benefit from these programs, and then get them referred to those services. The next slide, just the benefits to your participation. We lost that slide. The benefits to participation for specifically for primary care practices are that these efforts will help you to achieve quality benchmarks that I understand you may be working on. So specifically related to trying to improve diabetes control, specifically around also looking to offer interventions for people who are in that pre-diabetic range to prevent them from advancing into type 2 diabetes. And then also, I understand that you're, really pushing to increase referrals to evidence-based support. So through the, community network that we've been developing through the coalition, we're going to be increasing the availability of those opportunities, but we're really going to be depending on primary care to help get people to those opportunities. So, if you're interested, I will be reaching out to some of you probably directly in the next day. We need letters of support pretty quickly, but if you are interested, please do reach out to me. My email address and number are provided there, and Luann also knows how to get in touch with me. So I think I did that in under 10 minutes.
I think you did too.
I hope I did it justice. Does anybody have any questions?
All right. Let me get this down if I can. Okay. Katie Cook.
Good morning, everyone. It's been a while since I've had a chance to speak to this group, so good morning. Thank you to Luann and Brenda for having me on. I have a few updates as well as an ask of all of you, so there will be a little bit of open dialogue after I provide my updates. So for anyone who's on my email distribution list, you may have noticed that last Monday I sent out an update from M. Haney's that was sent to me around the governor's proposed telehealth reform. Very exciting stuff. And I can get a little bit into detail, but at this point, not much has been released from the governor's office other than the announcement that he's proposing telehealth reform. So the state is advancing a comprehensive package of telehealth reforms that will lower costs, enhance care for vulnerable populations, and increase access to telehealth services. So they have a few different facets of that. This regulatory reform will include permitting telephonic delivery of care, increased interstate licensure in the Northeast, which is really exciting. Up until COVID, New York State was not a part of the Interstate Medical Licensure Compact, allowing providers to practice telemedicine across state lines without having to be fully licensed in said state. So that looks to change. Allowing certain unlicensed staff, such as CASACs, to deliver substance use disorder services through telehealth, expanding the list of covered telehealth providers, eliminating some outdated location requirements, expanding reimbursement for remote patient monitoring, integrating telehealth into the Shiny, and requiring telehealth in commercial insurance, and expanding access to mental health and addiction services. So that's a lot. I haven't seen anything detailed beyond that yet. So we're kind of waiting to hear what may come of that. I am doing the New York State Telehealth Learning Collaborative this coming, looking up at my calendar, Monday the 25th at 2 o'clock. And we do have a representative from the Department of Health who will hopefully be speaking a bit more to this. So if you're interested in attending that, please send me a chat or an email and I can get you squared away. Other updates, as a part of this statewide telehealth reform, I'm sure you've all heard of the Reimagine New York Commission. One of the main focus areas of the Reimagine New York Commission was telehealth. What has come of that so far has been quite exciting. So the New York State Department of Health has put together this committee working with the Northeast Telehealth Resource Center as well as Stony Brook Medicine on Long Island, and they have released a New York State telehealth training portal. I will throw the link to that in the chat as soon as I'm done giving my updates. This training portal is still in development. The Northeast Telehealth Resource Center is putting together more modules. They actually are looking at AHI to assist with some of those modules, as well as DOH creating some modules in Stony Brook. So out of the NETRC's 8 states, they decided to choose New York to roll this out first, and they do plan to create similar training portals for other states. So it's exciting to see New York be up first. This was a part of the Reimagine New York Commission, and also at Monday's Learning Collaborative, Andrew Solomon from the NETRC will be giving some updates on this training portal, as well as some updates on a New York State Telehealth and Education Advisory Work Group, which I may be joining. So lots of exciting movement in the telehealth world. Those are the updates I have so far. What I am going to now turn to is a little bit of dialogue. I'm looking for some feedback or guidance from all of you who are, I understand most of you are practice managers on this call. So a little context towards my ask. I have been doing a number of COVID-related check-ins with our partners. We rolled out several equipment-based grants to support equipment purchases for partners. So I've been doing a lot of talking with partners and not enough with the community member side. So over the last 2 months or so, I've done a few community member focused presentations, and I've heard some interesting situations, some interesting stories, and it's led to this idea that AHI, me, creates this best practices for telehealth providers document. Reason being, hearing some of the patient stories indicated to me that practices are doing things very differently, and that the need, or at least pushing in the direction of more uniformity when it comes to telehealth visits, may be beneficial for our rural patients. I've heard stories around, well, this practice called me when their doctor was going to be late, but this one didn't. This one sent me a link only 10 minutes before my appointment, which made me nervous, but this practice sent me a link to my appointment a week in advance and gave me detailed instructions on how to access it. Even, you know, there's more nuances than that, but those are some examples. So what I'd love to open it up to all of you is a couple of questions. First and foremost, do you have some sort of tip sheet, best practices for scheduling and providing telehealth visits in your own practice? Has anybody created something like that yet? And I will call on people if nobody says anything. And if you haven't created that, why? How about that? Do you think it would be beneficial to your practice to have something like this?
Katie, this is Abe at Adirondack Pediatrics. We haven't created a tip sheet per se. I mean, we've been working with you for telemedicine for quite some time, like pre-COVID, and so for us, it's like continued. It's been like this continuing, evolving process, especially this past year with COVID. Like as situations have changed, so we've kind of put out like mini bulletins over time for like staff or how to like schedule. We've created new scheduling templates in our EMR. I mean, you mentioned that there's like this inconsistency about how reminders go out. That some of that may be EMR related or whatever platform you're on, because I know in MedEnt, they're continuing to evolve things. Like right now, when you make an appointment, it immediately sends the appointment message with and it asks you to test your connection to make sure that your device is compatible and everything, so you don't have problems at the time. But then you can also, as a user or as a practice, you can then set what time you want the reminder message to go out. So in our system, we've set ours to, they get that immediate when we're on the phone with them scheduling their appointment, and then they get a reminder 15 minutes before their appointment. And we were having our nurses connect initially when we see the patients coming on, but we were having some, I think we finally got them fixed last night. We were having some hardware issues that were causing us to have problems with our visits, so we weren't able to hand them off to a nurse and then have a provider pick up afterward to like let people know. So, you know, we've just kind of been adjusting and working so we can continue to move forward with offering that as a service. But I think different platforms are doing it differently, because like I've talked to my mother who has used telehealth through her doctor's office, and like they do it like completely differently. Like they call and like tell you like that the doctor's ready for you now. They don't actually give you like a set time. So like one of her visits, she was like driving down the road and they're like, well, we're ready to do your telemedicine visit. So, but
yeah, I'm looking to glean like what's everyone doing, and is it worth putting together, all right, these are some best practices that work well, knowing that everyone's system is different and you have to work within the confines of that. So that's helpful to know. I do see Lisa from Adirondack Health has a telehealth workflow for staff and a tip sheet for documentation for providers. Lisa, would you mind speaking a little bit to how you created that, and has it been helpful? And would you be willing to share it, even with just me?
Sure, I don't have it at my fingertips right now, but I'd be glad to email it to you to get it out to everybody.
Sure.
We worked with our HIM department to pull together the tip sheet for the documentation, and it details everything. So we've been working with WebEx, and then we just recently switched over to Doximity, which is much easier for our scheduling staff to work with and the patients than the WebExes. We use the Doximity as our primary platform. If a patient doesn't have a smartphone, we then revert to WebEx, or if that's not an option because they don't have a device or a computer, we refer to the telephonic.
Yeah,
it details.
Go ahead.
Oh, sorry. No, it details, you know, the documentation requirements. We've built a structured data field to include all the elements that they need for that consent, you know, location, all the different elements that are included in that. And that way they just can click through that. And then, you know, the tip sheet includes the codes that they should use and time, and just, you know, all the things to keep in mind when they're documenting for that visit.
That's great. If you wouldn't mind sharing that with me, it might give me an idea on how to start a document like this. So I appreciate that. Thank you.
Absolutely.
Anyone else have thoughts on if this would be beneficial if you created something like this for yourself?
I just have one other question. Like in our office, our telehealth visits are mixed in throughout the day with our other appointments. So I'm wondering, do like other practices, because like I've talked to like other practices where they've got like providers that all they're doing is just telehealth all day,
Right.
which I think that makes it easier to stay on, where when you're telehealth, maybe there's a perception with patients that, you know, because sometimes your doctor is running, when you're going in person, they're running behind and you end up sitting in the waiting room or sitting in an exam room waiting for them to catch up to you. And I wish there was like a virtual waiting room for telehealth, that instead of just staring at an empty screen while you're waiting to connect to your visit.
Right. I've had that happen to me personally, where I've been stuck waiting to be entered into a room for 15 plus minutes and not knowing what's going on. So yeah, anybody else on the line want to speak to how they schedule providers? I have heard both sides as well, Abe, that some weave it throughout the day, and some do, you know, in person only until a certain time, and then the afternoon is telehealth only, or some providers are strictly telehealth. I think it depends on the specialty as well. I think I'm hearing more behavioral health providers are doing full telehealth at this point.
If someone is speaking, we can't quite hear you.
No one has anything. That's okay. It's early. All right, well, those were the updates I had and some of the questions. I think we had a little bit of good discussion there to sort of get me in the right direction. I also want to plug the work groups that I'm running right now. Before I sign off here, I am spearheading 4 telehealth focused work groups right now. This was a result of a year-long strategic planning initiative that the telehealth program did. Outcome really was to continue the work. We should continue the conversation. So there is a broadband focused work group as it relates to telehealth. There is a commercial payer focused work group, a federal and state agency focused work group, and then a telehealth awareness and education for providers and patients work group. And that work group is today at 1 o'clock. So if anyone's interested in joining those work groups, please let me know, send me a chat. I can add you to the list. They meet monthly, and we've got a lot of the right folks on these work groups. So they're starting to really come to fruition and get some great conversation generated. And it's great to put providers and CMS and DOH all in the same work group and have them discuss what's going on. Okay, no shiny discussion has happened yet. The work groups aren't really focusing on that just yet, but that is a good consideration. So yeah, if you're interested in a specific work group, let me know. Otherwise, that was all I had.
Katie, it's Brenda. Are you able to hear me?
Yes.
Yeah, I've been the one trying to talk, but I was on permanent mute via my computer, so I think it's trying to tell me something today, which may be a good thing anyway. I just wanted to let everybody know Katie has done a tremendous job. She had a great meeting last week with the payers, and I've actually had a couple of meetings with payers since that meeting that had not participated, and just truly amazed with the work that Katie is doing in the region. So I just wanted to say kudos to you and thank you.
Right back at you, because those payers wouldn't have shown up if you didn't reach out to them. So I appreciate it.
I have some information I'll send you that one sent me yesterday, and just updates on where they're at. So
perfect. All right, well, thank you all very much for having me on and giving me a few minutes to speak. I'm going to stay on in case anybody wants to chat offline, but thank you, Luann and Brenda.
Absolutely, and thank you, Katie. And again, we'll have Katie come periodically because it certainly is helpful to get those updates. I don't have her email in here, but I'll add it to this screen so you can email her if you have any comments. As well, if you are interested in learning more about a potential, standard that she's going to try and pull together, or to even participate in that, it would be great. So that would be another way you could potentially connect with Katie. Next up, we have Megan Murphy. Are you there, Megan?
Hi. Good morning, Luann. Good morning, everyone.
Good morning, Megan.
Okay, you can hear me. I know, Brenda, I saw Brenda trying to talk and I'm like, oh boy, I hope I'm going to be able to unmute.
Yeah, something's going on because I'm literally sitting here with my hands folded and this screen keeps jumping.
Oh, wow. There's a ghost in the slide.
Yeah, I'm like, what? It put the old slides on and it's moving it forward and I'm like not touching a thing. So everyone's having a little challenge this morning. Technology, it's got to be our friend, huh?
Exactly.
Okay, so without further ado, I'm going to turn over to Megan.
Okay, so the topic, it just was proposed as COVID vaccine update. So I'm going to just give you guys a brief overview of what's happening in the region, and then and if you have any questions, I'll try to answer them. So I want to be sure everyone understands the state has organized our 62 counties into 10 hubs. They follow the Regional Economic Development Council lines. So actually this group is split into 2 different hubs. So the northern region is the North Country hub, and that is Clinton, Essex, Franklin, Hamilton, and St. Lawrence, Jefferson, and Lewis counties, so right across the northern region. And so Warren, Washington, and Saratoga are actually in the Capital District hub. But the hubs are organizing fairly similarly. One hospital has been designated a hub, the lead of the hub in each region. In the North Country region, that was CVPH, and in the Capital District, that's Albany Medical Center. And so for the North Country hub, which is the one that I am part of, our actual hub at CVPH consists at the moment of 3 people. That's Dr. Wouter Ritsuma, me, and Kelly Lang from the ACO is working on data for our hub. And so essentially at this point, all the hubs have been asked by the state to create something called a Health Equity Task Force. The state wants to be sure that as the vaccine rolls out, that we do identify and work on initiatives to engage some of our harder to reach individuals in our community. So in the North Country, we have 7 counties. In those 7 counties, we're working with the local health departments. Each of the local health departments has a county plan. They had a vaccine plan we had already, where they had already identified some of our hard to reach community members. So we're working with them on that. In the North Country, we have identified, we have a larger percentage of our population that's older. We think that they will, it is complicated with these vaccines. You know, at this time, we can't bring them to people. So people need to go to vaccination sites. And for some of our older folks, our disabled folks, we know that that will be a challenge. So that's something we've already started working with our county agencies on how do we address that. We've identified folks with behavioral health and substance use. We have Amish communities. We have some diverse communities that we want to ensure that they get good and accurate information and feel comfortable accessing the vaccine. So we're working with some community organizations that are active with our diverse populations. And so what we're doing right now is organizing some work groups around that health equity. One of the work groups, 1 or 2 of the work groups will be focused on communication and education, and the other will be focused on access. And so they'll be coming up with and working with health departments on how we organize those pods. And that gets to who is vaccinating right now. That's your hospitals, federally qualified health centers, the local health departments, and pharmacies. And in the North Country, the state itself has set up 2 state sites for vaccination. One is in Plattsburgh and one is in Potsdam. They can vaccinate up to 500 people a day at first dose. Once we hit the moment that people need to be coming back for second dose, their capacities will actually go up to 1,000 people a day. So they'll be able to do 500 first dose and 500 second dose in a day. And so that we are really excited about that. That will get folks that are able to navigate the internet, because you have to do that through the Am I Eligible app, and then also are able to move to vaccination sites. And so we'll be working very closely with our local health departments and others to try to set up sites in some other more rural areas, trying to think about, you know, how we reach some of our smaller communities. And I'm trying to think if there's limited eligibility right now for who can be vaccinated. You probably all know that. that's folks in the 1A category, and that's mostly healthcare workers and people who work at and reside in some residential homes. And then they have opened it up now to 1B, which is essential workers. It was initially people 75 and older, and they have now dropped that to 65 and older. And so those folks, really, the state has conceived of the pharmacies really focusing on those that are 65 and older. Also the federally qualified health centers, being able to look at their patients that are 65 and older. The hospitals are still focusing on the 1A population, and the state sites, again, are mainly for folks who are 65 and older. And so we do know that some of our practices have applied to be vaccinators. Currently, really what we're limited by is the supply of vaccine. We don't have much flowing at all. It's not some people think about it, about politics and what's happening. The reality is that there's just a limited supply right now. And so what we're doing, so that is all controlled by the state about who receives vaccine. And so we are trying to advocate that because of our rural nature, that we do start to get vaccine to some of our smaller providers, because we do believe that they will be able to reach the people that they need to reach. So did I see? No, okay, it's a different meeting that there's a chat popping up. I thought it was here. So I don't know if there are any questions or if I didn't cover anything, if anyone has anything they wanted to add.
Hey, Megan, I think it's Brenda. I think, if you wanted to share anything from your health equity meetings, or if there's anything that is kind of striking, I think, that's some of the stuff that we've been working on. And certainly I think it's a huge interest, to people on the group, if you're able to speak to any of that.
Sure. I mean, we've already started identifying some, and actually they're working with some folks in Clinton County. Clinton County Public Health did get a specific supply of vaccine for folks 65 and older, and they are tomorrow, Friday, setting up a pod at Plattsburgh Housing Authority. And some of the community-based organizations, actually on our meeting yesterday, we were sharing information about how community groups that work with our community members that are 65 and older could be helping sign people up. There were 30 slots left, we knew as of yesterday. And so everybody was working together through the chat to get the word out about how to get people to the vaccine more than just at Plattsburgh Housing Authority. So I think that's really the concept. We're still refining how that's going to work, and be especially across 7 counties, trying to keep track of where all of the vaccination sites are, when they're happening, and when people actually have vaccine to stand up the vaccination sites has been part of the challenge, I guess I would say. And so we're still trying to work out how we get that information out to individuals. In a way, the way that the vaccine's coming out as slowly as it is, to some extent, helps us get that structure into place. We also had a good conversation around migrant workers yesterday, and who has trusted relationships with them. Farm workers are considered essential workers, as are a number of others. And so we're really trying to think about, how do we leverage the existing relationships that exist in the region with those that are already working with them. One group we have also identified is the Amish community. Essex, Clinton, St. Lawrence, and Jefferson and Lewis have Amish communities. And so we're trying to kind of dig into, who has the relationships with them, that we may be able to at least start conversations with them and help them get information and that they need, and see if there's the ability to think about, their how this might fit with their culture, and the concept of vaccination.
Thank you. That was great.
Are there any other questions?
Thank you, Megan. And I just want to thank you all. The North Country Hub has been doing phenomenal work. And I know we've had several outreaches from some of the other hubs because it has been communicated how well they've gotten their vaccine process up and running and tracking. It really has been a monumental feat. And that goes to say that it took the entire village, if you will, of all these counties to come together and really help to support and participate in all of these efforts. So you see anyone that's been participating, please give them a big thank you as we try to continue to work through all of this. Okay. And now I would like to welcome Brenda as usual. Could you please give us some updates on quality metrics?
Sure.
And I think on the electronic clinical record.
Sorry about that. I'm having, I guess, difficulty staying. I'll talk on the phone. Anyway, I think one of the things that I wanted to address is the fact that, I tried talking when Ann was on, and I wasn't successful. Certainly, when we're talking about, the different programs that we have to support our patients, it's a great opportunity to be able to have our community-based organizations to be able to help support us and being able to provide these type of opportunities for our patients. I think right now, all the providers are struggling with COVID, and trying to get people in, the telehealth issues that may be coming up. So there's a lot of other things, but to ensure that our patients have the right supports once they leave our office or leave a telehealth visit, it's great to know that we have the ability and would have these opportunities to refer patients to the CD, whether it's the diabetes program or the chronic disease self-management programs, to allow them to be able to better self-manage their disease process. So I think it's a great opportunity, and I know Ann has been working. This is the second grant that she's in the process of submitting, really on our behalf. And again, it goes back to, I think, talking to the point that Luann was speaking to about the work that's being done around the hub. I think our region has been working together for for quite a long time, and really understands our region and understands the need. So being able to pull together to pull these things off is really important. I think this is just another step to help us better support our patients in our region. So I'm not going to spend a whole lot of time. I think it's just really wanted to touch base on the electronic clinical quality measures. And I know many of you who are on the phone have heard me a couple of different times, regarding the ECQMs and kind of the direction where we're headed. We know that New York State is headed down the electronic clinical quality measure route. It's a lot easier. It's much more efficient, and again, certainly it's where we're headed, and there's been a lot of talk about that for a long time. For the people who are on or are part of the ACO and our Medicare Shared Savings Program, we are in the process of making a decision as to how we're going to submit our data this year, instead of having to do a data extraction like we've done in the past, and what we're currently doing. But to just briefly talk about this, I think we all have the capabilities, and everybody who's on who is meets NCQA recognition as well as anybody who is submitting data. Your EMRs are set up to be able to capture these data points, these electronic clinical quality measures. And certainly it's very, the advantage for us to be able to utilize those metrics that are already set up in your EHR is just really, it's time saving. It provides a consistency and uniformity on how that data is transmitted and how we collect it, and really reduces errors. But I think we've learned through the years, in fact, I just got done doing a data abstraction at one of the offices. One of the issues is there's 7 different providers in the practice, and they each have a different template, and they're specific to the individual. So when you're trying to locate something, I had to learn, okay, for this provider, this is where I need to go to locate this piece of information I'm looking for. So if each of those templates are not mapped correctly, then some of that data is not being collected. And so certainly the barriers that we're currently looking for, and yesterday I did send out to the practice managers who are participating in the Medicare shared savings world, the ability, requesting them to send us their data on the 3 clinical quality measures. And certainly right now, and Luann is part of this as well, as we move forward, we want to be able to see how well did we perform in 2020. And the 3 measures that we're looking at currently is the depression screening, which all of you are very familiar with, is the preventive measure that we screen yearly, and if somebody scores positive, that there's the appropriate follow-up. And then the other 2 measures, which are poor diabetes control, A1C greater than 9, and so that is an inverse measure. So certainly the lower the score, the better we're performing, and we do very well in that when we're doing the data abstraction. And I think we do fairly well as long as in the practice, when you're pulling that, as long as that A1C is put in the structured data field, is going to pull correctly and it should reflect, as well as controlling hypertension. The big difference for us this year, if we move to that, it does reflect your total patient panel. And we're looking certainly when we're talking Medicare and we do data abstraction, it's just our Medicare patients. So a very big switch. The ACO will not have a choice in 2022. It will have to be electronically. So right now we're just kind of, working, want to work with the practice, have a better understanding of how that looks when you pull those measures from your EMR, and where you may need assistance to help improve the pulling of those reports to ensure that we're getting the best possible results that we're pulling from your EMR. Certainly, a lot of times, one of the things like for controlling high blood pressure is we want to make sure, that if people are taking a second or third blood pressure, that we're collecting that in a structured data field. And I can honestly say in a lot of the charts that I look at, a lot of times it's in a free text. So those are some of the things that we'll have to start looking at now, and how we can help. And I think, right now I would be interested to hear how people utilize their dashboards in their EMR to be able to monitor what kind of follow-up or validation do you do. Do you work closely with your EMR to get, to align those measures better to ensure that everything is mapping correctly so that you could report out? So that's, I just wanted to give an update as to where we were, and I think future meetings more, we will be focusing on that and requesting feedback, and really looking at how we can best support each and every one of you through this process.
Any questions?
Brenda?
Yes.
Brenda, this is Erin from Hudson Headwaters. Question regarding the EMR. So we have our Athena EMR, of course, that we use, but we have built out a different dashboard chart scout on top of that with an outside entity, but it pulls directly from our EMR, and that's what we use to report out any outreach reports, et cetera. We find it to be more valid and accurate on data than we find Athena to be. And so I'm just curious, does the do the 3 ECQMs have to be pulled out of your, like, would we have to pull it out of Athena, or can we pull it from Chart Scout since that is pulling from Athena as well?
So is Chart Scout a registry? And are they a recognized vendor by CMS?
They are a recognized vendor by CMS, yes.
So it's Chart Scout. I'd have to reach out. I personally believe that, so there's different things. Right now, I don't think we can turn around what we would have to look at 2021. I'm just going to use that as a for instance. We're not in a place, I think, to report through a registry yet, the whole ACO. I think we're going to get to that point, but right now we're not at that point. And it would be the feed directly from your EMR. So I will check with NACOS, who is our, it's our ACO advocacy group, and certainly I can, follow up with them. But I believe I'd have to see if they're on the recommended MIPS vendor list to be able to report those that way. Okay, so, and I'm not sure that they would be, but if you could just send me the name of that, and then I can certainly ask them.
Okay, I will do that. Thank you.
Okay, thanks.
I think they did just come out too, Brenda, with a list, if I remember one of those emails that's been flying across my screen here of those.
Yeah, they just came out. I'd have to look. That's
Yeah,
what I mean. I don't know the registries off the top of my head.
Yeah, no, there's a huge list. But just so you know, Erin, there is a, through MIPS, there is a list of what those acceptable registries are. And I would actually just call that out for anyone that might be considering going down this road to make sure whatever you're going to be using, be it your own EHR or a third party, that you make sure they are an acceptable registry, because that would be awful if you did all that work and then they wouldn't accept it.
Well, and I think, I believe, when we look at some of the people who are on the call, or anybody that's on the call, going through a registry, what's the cost? What does that look like? And I think if working with your EMR vendor to ensure that things are mapping correctly and things of that nature, I think, there's opportunities there because our providers already, I know that you're all submitting your data and should be coming up where you will be submitting for promoting interoperability directly.
Right.
This, so you're already doing it. Your EMR is capable of doing it. I think at some point, for us, when we get down, being able to do for the ACO one submission, that would be a great opportunity for us to be able to do that. We're just not there, at this point. I think, that's something certainly for the future. But anyway, I will check that out, Erin, and get back to you on that. So.
Yes.
Great, thank you. And I just realized I used the wrong name. I totally was not talking about Chart Scout. I meant Relevant.
Relevant.
Okay.
Yeah. But I'll email you, Brenda, with all the information.
Okay. All right.
Thank you.
And I'm sure this will not be our last discussion as far as the electronic submission goes, as the ACO continues to work through and trying to figure out how best to meet these needs and potentially look forward to 2021's submission in 2022. We'll have multiple discussions. Any other comments or questions about any of the quality initiatives going on, your submissions, challenges, successes? No.
One thing I just want to announce, tomorrow, for any of you who have pediatrics in your practice and want to participate, the pediatric work group is tomorrow. Their meeting is from 7:30 to 9. I can forward that meeting. It's kind of an introduction for anybody that has not participated in the past as to what has been happening here in the northern region. So Dr. Began will, be giving a great overview and kind of the direction that work group will be taking. So if you'd like me to forward that, just please send me an email and I can get that to you.
Great, thank you, Brenda. just a couple topics looking ahead. Because the depression screening is such a hot topic with submissions and whatnot, we hope to have that discussion ready and available next month. And we'll be working both with the quality initiatives and also looking at the Hicks New World to see how we can bring that workflow and hopefully standardize that or make some recommendations that people might be able to utilize that workflow. If you have something along those lines that you are working on with your depression screening and getting it submitted into the HIEs, either be prepared to discuss it with us, or if you have information ahead of time, please send it forward. That would be great. The other area that we're working on is actually getting some of the EHR vendors to participate. And we're hoping to start off with MedEnd, but we do not have that confirmed yet. But again, trying to speak with the EHRs and talk through some of the metrics and the measures and how they work and what's going on. I think it would be helpful for all of us. And as always, if you have any topics or suggestions for topics, please send them forward and we'll see what we can do to get them together for you. We have about 2 minutes. Does anybody have anything they want to mention or share or ask? Okay. I hope everyone is staying safe and healthy, and we will see you next month. Thank you.
Thanks, Luann.
Thanks,
Thank
everybody.
you. Thank you,
Thank you,
Luann.
everyone.